Just the audio or video as well?
Well, just really the audio is what I'm.
All right. You want to put it there or no? Yeah, it's fine by me, whatever. So how have you been?
I've been okay. I've been fine. Yeah, I've been a bit sleepy, a bit tired all the time, but apart from that, it's been okay.
Wounds from the previous operation have been fine?
Yes, they've been great. Yeah.
And bowels been working fine?
Yeah, they've been working fine.
And you have seen, you were seeing Dr. Samuel, isn't it?
That's right. Yeah.
And what about chemotherapy?
It didn't really shrink the tumour, so.
And how many cycles you've had?
4 cycles.
Yeah.
It always shrunk it a little bit.
Yeah. It's not uncommon. It can happen.
Okay,
I think that when this happens, it's reasonable. With hindsight, things become easy. And with hindsight, you can think that it may have been better to remove it without chemotherapy. But there would be a significant number of patients for whom it shrinks it, and that means that much easier and smaller operation, retaining a more proportion of your liver. But as it is, we are at the stage of again another operation, which would be an operation on the liver to remove essentially the left half of the liver. Is something which I have discussed with you before.
That's right, yeah.
The left half of the liver is essentially about 40% of your liver in total. As it is a big liver operation, but as the big liver operations go, it's a relatively straightforward of the big liver operations, and you're left with 60% of your liver, which is quite reasonably enough to help you recover, and the rest, the liver which is left behind, it grows back to almost as the starting size of the liver is. I say almost because the size of the liver is determined by what your body's need is. So as much as your body needs in the long run, the remaining 60% will grow back to satisfy that need. The rationale for removing this is the only point where you've got the tumor at the moment, as far as we know at this stage, knowing fully well that you are having a scan tomorrow, which can sometimes show us new things, and we wanted to sort of put your operation after that scan so that we know exact situation. But after all, at some point we've got to discuss these things, and if the MR scan shows something different, then we'll have to go back and discuss the other options. But as currently we're hoping that it just doesn't show us anything further, and we can proceed to this operation, which will be this time it will be a big cut. Last time we did the keyhole operation, but this time it will be a big cut. And you'll probably be in for I would think about, last time you did very well, but I would think that it would probably be 7 days you're in the hospital. Just like any big operations, they've got the risks related to being anesthetized, so you can have risks from that sometimes, and the anesthetist will speak to you about them in detail. From the surgical perspective, wound infection, bleeding, sometimes over the long run people can develop hernias. And the liver operation itself, when we cut the liver, I would not expect you to have any insufficiency from the remaining liver, because you've got enough, but very rarely people can go a little bit yellow, and they gradually recover as the liver picks up. And liver is sort of like a sponge full of blood, and when we cut it, we try and stop bleeding and everything, but sometimes people can bleed after the operation, and sometimes during the operation, and they need blood transfusion. And very rarely people can need another operation to stop the bleeding. And similarly, just like blood, there are very tiny tubes which we can't see are passing through the liver, which collect the bile which the liver produces, and they can sometimes leak bile after the operation, and that's why we leave a tube in the tummy, and it takes out if there's any bleeding or bile Sometimes it doesn't take out, and then very rarely people can need another procedure like a scan and then putting a tube in, or sometimes they can need another operation. And as I say that this is a sort of a relatively more straightforward of the big liver operations, but even then there is some chance of dying from any operation on the liver. So you just have to be aware of that. I would think that it will be sort of in the region of about 1%, 1 in 100. Why are we doing this? As I would have told you before, I'm telling you again, that invariably cancer wins the war. Okay, this is a battle. Okay, we won one battle, and we are trying to win another battle. And for a great majority of patients, by going through this operation, what we are doing is buying more time. We call it cure if we know that you've got just a tumor and we removed it completely and you've recovered from it. Okay, but it may not completely be as you understand a cure, because the tumor can come back, and it can come back in the liver, it can come back in the lymph glands, it can come back in the lung, and it can come back in other places. And so after the operation, I think, as previously you've not responded well to chemotherapy, you probably not have any more chemo, but that is a possibility. But very likely, once you recover from the operation, you'll go into having further scans, which will be at 6 monthly intervals. And if, well, I say if, but let's say that a lot of people do get the tumor coming back, and then we've just got to decide it on its own merit whether you can have another operation. There are people who can have 3, or I'm just doing another. When we plan your operation, it's very few days after I'm doing another operation. This gentleman is having his 4th liver operation. So you just have to sort of put this in perspective with that unfortunately, once we've got cancer, life is not the same again. Scans and this, that, and the other, and I'm afraid it's just we try and support you, but you've got this thing to understand.
Okay, yeah.
So the current situation is you're having a scan tomorrow.
Okay.
We will see the scan, we will rediscuss it, and if there is anything changes, then I will bring you back. Otherwise, I will just write to you that there's nothing to worry about in the scan.
Okay.
And we'll proceed with your operation if that's okay with you.
Okay.
Okay. Have you had pre-assessment yet?
No.
No.
Well, not for this operation.
Yes.
No.
So you will be getting pre-assessment, and have you got a date?
Yeah.
Well, I think we've got a date for you in mind, either end of June or early July.
Oh, for the operation, you mean?
Yes.
Oh, okay, it's 9th of June, I heard.
9th of June.
Yes, they moved my scan to tomorrow because they wasn't time to report it.
I think it's not 9th of June.
Oh, really? Okay.
No, I think it's not 9th of June. I think it is because the scan has been delayed and the pre-assessment hasn't happened. So we didn't think that all of these, and we need to discuss your case on the MDT after the scan.
Right.
So I think it is probably end of June or early July.
Right, okay, that's what I understood before.
Yeah,
but
yeah.
They heard that they moved the scan to tomorrow because they wasn't time to report it before the operation, which is booked for the 9th.
Yeah.
They told me.
Yeah. All right.
Yeah.
As far as I was trying to get you, because initially your scan was, I think, on the 7th or the 8th.
Right, yeah.
And I was trying to sort of get it forward, and it wasn't getting forward, so I moved your operation.
Okay.
And once we moved that, I think they have moved your scan, but I think that that should be okay. That should be okay.
Okay.
Now the important thing is what sort of questions you've got in mind about all of this.
I think I understand that. Well, this business about being a cure, not being a cure, I think other people are getting confused. They think the cure is that I'm fixed, basically, and there's no problem. But whereas I understand that it's not a problem. The cancer's still there somewhere. It's just a case of when it appears again.
Not necessarily.
Okay, nice.
Yes.
Okay,
So
okay,
you
okay.
see, there are a lot of things. There is no black and white.
Okay,
here.
okay.
As we cleared out the tumor from the colon,
Mhm.
at that stage you realize that we thought that we've cured you. Yeah.
Mm.
Now, from the colon point of view.
Okay. Right.
But we've got the liver issue.
Okay.
So now, if I give you another example, just say, for example, there's another person who's got tumor in the colon. We take it out, okay, we clear their tumor. A year later, they can get a tumor in their liver.
Mm.
So you just have to understand that there will be a significant number of people who will still get cancer recurring.
Yeah, sure.
And the reason for that is that from your early tumor, there may be some very tiny cells sitting somewhere. And they, with time, they grow, and at this stage, they may be somewhere, but we don't know where they are.
Yeah, sure.
So it's a different. This cure is a little bit different as you would sort of expect. There would be a proportion of patients where the tumor would never come back, but they are fairly small.
Sure. Okay. Because it's not responding to chemotherapy, I guess my only operation is surgery.
Yes.
And if the tumor grows somewhere but there's no surgery possible, then
that would be. Well, there would be some chemotherapy options which are more toxic.
Yes.
And when there is absolutely no other option left, they can be considered.
Okay.
But at this stage, it's just much more better to proceed to surgery
Sure.
rather than anything else.
Yeah. I mean, I'm trying to think about hindsight either, because I really did want to get it out before, but
I realize that.
Yeah,
I
makes
realize
sense,
that, and I realize
yeah,
about everything.
yeah,
And as it happens, unfortunately, I haven't had a chance to speak to you since then because of one thing or the other. But we just have to take a decision on what we can see. And what we may be wrong, but what we take a decision on what at that point all of us think that is in your best interest. Okay. I mean, of course, we can only suggest, and it's not a compulsion, but we sort of give you a firm recommendation that we think that this is in your best interest. And I mean, as I said at the very start, that with hindsight, things can appear to be appear to be different, but there will be a lot of people. I mean, in the recent sort of past, I would probably be seeing maybe 40, 50 patients a year or more of this sort of thing, and there will be, here is the one, and there's only one more which comes to my mind in which the tumor hasn't shrunk. So I mean, there would certainly be more, but the percentage of those patients is not high. And the other one very important thing what you got to realize is that it's the aim of this chemotherapy is not only to shrink the tumor, but it's got another very important aim, which is that when we look at this very poor type tumor, what we are worried about is that this lump that we can see is only one lump, you see, and we do an operation to remove this lump. As I say, that it's not the biggest operation that we do, but it's still an operation. It's a risk of dying, it's a risk of everything. And what if a few months later you've got tumors in the lung, you've got tumors all over the liver?
Yeah,
So
that's it.
with the with poor biology tumor, with aggressive type tumors, that's a big concern. And this chemotherapy time has also bought us this time to see how you are over the next few months. Okay,
Okay.
and as we can see that the tumor is just limited to there, or as far as we can see, it's limited to there. So we can go in with a lot more confidence.
Okay.
That's it's just not the shrinking, but to also to see that we're not doing something which is going to take a lot out of you, put you out of action for few months, and then you've got tumor a lot other places.
Yeah.
So that's another aspect to all of this as
Yeah,
well.
sure. Is there? I guess it. Gosh, I've got questions. I can't remember offhand now. But now we know more about the tumor. Is there more idea of the outcome, the prognosis, how long I would have roughly? Or?
Well, I mean, roughly would sort of expect that life expectancy would be more than 5 years in 50%, more than 50% of the patients.
Okay.
For an individual, it's very difficult to say.
Yeah, I just was wondering if, because with it not responding to chemo and being aggressive, and I wondered which 50% I was more likely to pull into. See what I mean? But
I would go in that hopefully you will be the 50% who will be alive and kicking,
Okay.
walking around on the Aberdeen beach.
Okay. So it's going to be the big operation this time.
Yeah.
I can't think of. I really can't think of questions offhand now.
Well, I mean, I can bring you back if you've got any questions, or you can ring my secretary and I can call you.
Okay.
So that's not a big deal. If you've got a question, you just have to ask and we'll get back to you.
Okay. Yeah, that's. I think that's pretty much everything. Yeah. Okay. Thank you.
All right.
Thanks.
So you're gonna get your pre-assessment appointment. You're gonna get your scan, and either I will call you or I will write to you after we've